This is Ian Bodrick.
And Liang Liu.
And welcome back to the Clinical Correlation. Today's case is...
The patient is a 20-year-old female with no past medical history brought in by EMS after a motor vehicle collision. She was seen at an outside hospital and transferred to a trauma center.
She was the restrained driver of a vehicle traveling at highway speeds when she was T-boned on the driver's side by another vehicle.
She is complaining of lower abdominal pain and seatbelt sign can be seen on exam. The outside facility had placed a Foley which was draining blood-tinged urine as shown here.
Hematuria in trauma can be microscopic or macroscopic, though up to 5 red blood cells per high-power field are allowed due to trauma associated with urinary catheter insertion.
Generally speaking, the greater degree of hematuria, the greater risk of significant intra-abdominal injury. However, hematuria is not necessarily seen in some renal or renal vascular injuries.
Management of hematuria depends on the mechanism of injury and patient presentation. Generally, with penetrating trauma, the wound is explored or the patient is taken for exploratory laparotomy.
With blunt trauma, management depends on the degree of hematuria and stability of the patient.
Prospective studies show that of 365 patients with microscopic hematuria without hemodynamic instability, only one patient had a renal injury severe enough to warrant further studies.
Therefore, the American Urologic Association and EAST guidelines suggest that asymptomatic patients with microscopic hematuria and blunt trauma require no further imaging. They can be followed up with repeat urine analysis in 1 week with PCP.
However, due to the differences in pediatric anatomy, expert opinion suggests that imaging is still indicated in pediatric patients with asymptomatic hematuria as they are more vulnerable to significant renal injury.
In blunt trauma, patients with gross hematuria or with microscopic hematuria who are unstable, defined as a systolic blood pressure less than 90, a CT is needed to evaluate for additional damage.
Additionally, CT is indicated in patients with significant mechanism of injury, including rapid deceleration, significant blow to the flank, rib fractures, significant flank ecchymosis, penetrating injury of the abdomen, flank, or lower chest.
Keep in mind that 50% of patients with macroscopic hematuria in blunt trauma have renal injuries, and a further 15% have injuries to other intra-abdominal organs. So for these patients, add on the CT cystogram to your CT abdomen and pelvis with IV contrast.
In patients with a suspected urethral injury, a urethrogram should be done to confirm. Though classic teaching for this includes blood at the meatus, perineal or scrotal hematoma, and high-riding prostate, these findings are uncommon.
More likely, patients will have gross hematuria, potentially difficulty placing a urinary catheter, and pelvic fractures, especially displaced fractures of the pelvic ring.
In our patient, a bedside FAST exam was performed, which involves 4 views of the abdomen looking for free fluid.
In the right and left upper quadrants, there are 4 spaces in which fluid can collect: the pleural space, the subphrenic space, the hepatorenal or splenorenal space, and the inferior pole of the kidney.
The subxiphoid view can reveal any pericardial effusion, and the suprapubic view looks at the retrovesicular recess, also known as the pouch of Douglas.
The patient's ultrasound showed no pericardial fluid, pleural effusion, or abdominal free fluid in the upper quadrants. However, the suprapubic view was odd.
On ultrasound, the bladder is seen, but the Foley balloon is not within the bladder. There is also loss in the distinctiveness of the bladder and free fluid in the lower abdomen. A CT abdomen pelvis was obtained for further evaluation.
The CT notes bladder rupture with moderate extraperitoneal fluid with a small amount of fluid between the bowel and Morson's pouch, favoring an intraperitoneal component. Mild bilateral hydrourethral nephrosis is present.
Urology was consulted and a CT pelvis cystogram was done confirming the extraperitoneal bladder rupture with a large wall defect measuring 4.5 centimeters involving the 9 and 12 o'clock axis of the bladder.
Bladder injuries are most commonly due to trauma, and especially blunt trauma, with MVC being the most common mechanism.
About 10% of patients with pelvic fractures will have urethral trauma and/or bladder rupture.
Ruptures are classified as extraperitoneal perforations, which account for 50 to 71% of bladder ruptures, intraperitoneal, which accounts for 25 to 43%, and combined accounting for 7 to 14%. Intraperitoneal perforations are more common in children as the bladder is an intra-abdominal organ. The bladder descends into the pelvis by the age of 20.
While overall mortality due to bladder injuries is estimated at around 20%, a combined rupture carries a 60% mortality rate, which likely is due to the concomitant other injuries seen in the combined rupture.
Bladder injuries can also be iatrogenic due to intoxication or spontaneous. Iatrogenic causes include intra-abdominal surgery, orthopedic hip procedures, and even intrauterine device insertion and indwelling Foleys.
Generally, management of bladder injuries is conservative.
Bladder contusion and hematomas can be observed.
Intraperitoneal rupture requires laparotomy and surgical repair.
Extraperitoneal ruptures can often be managed with maintaining a Foley, usually for about 10 days.
To summarize, look for hematuria in your trauma patients as a sign for urologic damage. A UA with more than 5 red blood cells per high-powered field should not be attributed to a traumatic Foley insertion.
The stable asymptomatic adult patient with microscopic hematuria can be sent home with PCP follow-up and repeat UA in 1 week.
All other blunt trauma patients need a CT. Those with microscopic hematuria but unstable, those with gross hematuria, and those with a good mechanism.
Penetrating trauma involving the abdomen will need at minimum local exploration and more likely an exploratory laparotomy with evaluation of the GU system intraoperatively. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLLou.
Thanks for listening.